A very good afternoon to all of you, and today I'm going to discuss a very important topic on breast, and that is Paget's disease of the breast. A topic which is not often discussed, and you don't come across it so often that you are able to discuss this topic. So let me just take you through this topic, which is first credited for its clinical description by Welpo in 1840. When he described the visual surface lesion of Paget's. So Paget's, we know it essentially presents to you with involvement of the nipple and then maybe the areola also. So now the clinical findings associated with this cancer, with the underlying cancer, was described that this Paget's is not just nipple and areola, but it also has an underlying cancer. This was described for the first time by Sir James Paget, and that is where Paget's disease gets its name in 1874. But of course, he was erroneous in saying that the skin manifestations of Paget's is actually benign. So it was Thin finally in 1881 who said that the nipple lesion was not benign, it was malignant. So now, how does Paget's disease happen? So there is this, did the egg come first or did the chicken come first? So you do have that kind of a theory to Paget's also, whether the disease starts from the skin and goes into the breast, or does the disease originate in the breast and comes on to the surface. So there are two theories which go in to tell us whether it is which way, and that is one must know that Paget's constitutes only about 1 to 3% of breast carcinomas. So let me just come to the first theory, and that is the epidermotropic theory. And this was propounded by Jacobius. So what he said was that Paget's cells arise in the lactiferous ducts. So you must understand that the lactiferous ducts, when they come onto the surface of the nipple, they're actually, there is a boundary with the skin. So that is how it spreads from the ducts. It goes through the lactiferous sinuses to the nipple epidermis. So that is how it spreads to the skin. And why did they say that it is breast and then skin? That's because the immunohistochemical profile and the gene expression of both these cells within the breast and the skin was similar. And then there is also this concept of this factor, which is a motility factor, which is known as heregulin alpha, which is known to draw these cells from the ducts onto the surface, that is into the skin. And one must understand that Paget's disease is usually associated with an underlying carcinoma, and that happens in about 90% of cases. So then, what about the other 10% where there is no underlying carcinoma? So how do you explain Paget's disease in isolation alone? So that is where the second theory was propounded, and that is the intraepidermal transformation theory. So the understanding is that the Paget's cells, they arise from a transformation of multipotential cells in the epidermis or from the terminal portion of the ducts at the junction with the epidermis. So the core of this theory are the Toker cells. So Toker cells are propounded to be precursors of Paget's disease located in the skin of the nipple areolar complex. Besides this theory, there are other studies which have identified desmosomal attachments between Paget's cells and the skin cells or the keratinocytes, and this supports the in situ development of Paget's disease without the presence of an underlying cancer. So if you look at the ultrastructure of these Toker cells, these are globoid cells, and they are very, very similar to Paget's cells immunophenotypically. So independent of the origin, the similarities between the Toker and the Paget's cells suggest that the former may actually be the seed cell which undergoes malignant transformation in the initial phases of the Paget's disease. So the Paget cells lies between the keratinocytes of the nipple epidermis. They occur in single form in the superficial layers, and as you go down deeper, you find clusters towards the basement membrane. So what happens is the serous fluid, because of the disrupted keratinocyte layer because of these cells which have insinuated between the keratinocytes. The gaps between the cells allows for serous fluid to come on the surface, and that is what gives rise to crusting and scaling of the nipple skin. So if you look at the pathology, the Paget cells are pleomorphic. They have a very prominent nucleoli, frequent mitosis, just like any other neoplastic cell, and they show intracytoplasmic mucin-filled vacuoles with clear or pale cytoplasm, and they're situated individually or in clusters, like I said, superficially in singly and deep towards the basement membrane in clusters between the native epidermal keratinocytes in up to 25 to 50% of cases. So now this epidermis can also show other things like hyperkeratosis with parakeratosis, hyperplasia and papillomatosis, leading on to ulceration and crusting also. So the underlying dermis will show reactive changes, including a lot of times you get this lymphoplasmacytic infiltrate, and there is a lot of hypervascularity which happens here, and that is one of the reasons you get a lot of bleeding from the surface also in these patients. So what is the clinical presentation? So I always think that one must lend your ears completely to the patient when she is relating the history. So in 40 to 50% of cases, there will be a palpable mass at presentation. That is the easier bit. And some patients may even present with an enlarged axillary node. So we don't want to catch them at that point. We want to catch them when things are just beginning to happen. So the majority of Paget's disease patient will give you a history of scaling, erythema, ulceration. So scaling, erythema, ulceration with itching. And there could be pain or burning sensation. There could be bloody discharge on the surface. Don't confuse this with a nipple discharge. A nipple discharge is a different entity where the discharge is coming out of the ducts. That is where the discharge is happening. But here, if you look at this picture, so this is the area which is not looking right, where there is crustation and sometimes the crust falls off. There could be bleeding from the surface. So that is what you get in Paget's disease. And the important thing is, like I said, that history may be prolonged. The patient may actually be coming to you and you may be missing it completely because you may be seeing the patient in a time when the nipple is completely normal. So she is going to relate to you a history that there are repeated episodes of crust formation, falling off, there is bleeding from the surface, then the crust forms again, and in between the nipple is absolutely fine. But that must up your ante. So this is what is going to happen in the initial times. And it is here that you must intervene and not wait for a time when an underlying lump has formed. Usually you will see that it is the nipple that is involved, like in this case, but in long-standing cases, you can have the adjacent areola also involved, and you have this kind of eaten up appearance when the nipple is completely disappeared or eaten up by the Paget cells. So how do you investigate these patients? So these patients can be investigated by a scrape cytology, but a better investigation would be a wedge biopsy of the skin and the underlying breast tissue. So you need to get the skin as well as the portion of the duct. So that is what is very important. You can do the same thing with a punch biopsy also. So punch biopsy, you'll get a cylinder of skin. So suppose this is the nipple, and if you do a punch, you actually create a little crater and you get a cylinder of skin, that's the dermis, and here you would get the ducts as well. So that is the idea. So you must have both skin and the duct. So this is what a biopsy will give you. But even before you do a biopsy, you can do a mammogram. And this mammogram, unfortunately, in case of Paget's disease, does not have high sensitivity because here the disease is confined only to the nipple. And if you do not have an underlying malignancy, the mammogram may not be very contributory. But having said that, usually you will find something underlying the Paget's disease, especially of long-standing duration. And therein, you will find abnormalities on the mammogram also. So on mammogram, you can have skin thickening, there could be nipple areolar thickening or retraction, there could be subareolar or diffuse microcalcifications which are very, very pleomorphic, or you could have a discrete mass or some architectural distortion like you would in any case of an invasive carcinoma.